Great. Thanks very much, Ajaka, and huge apologies for not being able to hang around for the proper question and answer session. What I will do is go through my slides reasonably quickly, so hopefully we have time to answer what you've got. So let me just see if I can share my slides. Do bear with me a second. I hope you can see my slides now. So what I've been asked to talk about is the NIHR National COVID Vaccines Programme, and I ended up, I'm not quite sure how actually, being the national clinical lead for this programme. So I know we've got a mixed audience. I assume probably most people have heard of the NIHR, the National Institute of Health Research, so I'm not going to go into detail about it, but I wanted to point out the last thing on the slide here, which is that we actually probably have the most integrated health research system in the world. That's all very good, but I'm not sure we've seen that transferring into delivery. And that includes vaccine delivery in adults over the last few years or the last few decades. But I hope things are going to be different going forwards, which is part of what I'll focus on right at the end. So the important part of the NIHR, I'd argue the important part of the NIHR for the COVID vaccines currently going through is the Clinical Research Network, the CRN. There are a family of organisations as part of the NIHR. The CRN really is the delivery arm of research from anything from phase 1 to phase 4. Phase 1 does overlap a little bit with the BRCs, the CRFs and some of the other organisations under the NIHR umbrella. So this is what the local clinical research networks are. So we have an overarching coordinating centre, it's called, for the CRNs. And then it's regionally based, as you can see here, 15 regions. What is really important, though, to acknowledge is that for COVID vaccine research, we add an extra 3, which are the devolved administrations. So they have different infrastructures, different IT systems, but we've worked closely, well, as closely with them as we have with any of our other regions. So it's actually 18 regions. And this is a partly corporate slide talking about goals and enablers, but I took it out of the data sets because I wanted to focus on 2 main things, which are in red here. So first off, the CRN working as a single network to improve the delivery of high quality clinical research. And secondly, provide a coordinated and innovative approach to national research priorities. And I personally think that our efforts towards COVID vaccine research have really exemplified these 2 areas. So what was the ask when the network set up to undertake COVID phase 2, phase 3 and some phase 1 still research? Well, the original ask, and we're talking about early summer now, was to set up a delivery system for anything from 8 to 15 phase 3 vaccine studies, each enrolling between 1,000 and over 20,000 individuals around the country. There was a request for good geographical spread. Now, what I mean by that is that we wouldn't focus a particular protocol in one region of the country, for instance, the Southwest or the Northwest. And that was really to acknowledge that at that stage, and even in the future now, we don't really know where the epicenters of coronavirus transmission are going to be. And for these phase 3 studies, the endpoints are really acquisition of coronavirus and severity of disease. So each of the sponsors, whether they were academic or commercial, really wanted a good geographical spread. Initially, all 18 regions being included, though there's been some flexibility in this. But again, still, we want things in the north, south, east, west, central, etc. These 8 to 15 phase 3 studies were thought to come over the next 6 to 9 months. And this was going to be delivering this, taking into account the stresses and strains that were already on the health system and on the research infrastructure, but also an attempt to try and do these with the least impact on other studies and other research. So that doesn't include just COVID research, so that's vitally important. But could we undertake these large-scale studies while still continuing our cardiovascular, our neurology, our psychiatry research, etc.? You're probably all aware of the National Vaccines Task Force, headed by Kate Bingham under BASE as a government body. And the National Vaccines Task Force has reviewed various protocols and liaised with various sponsors about studies that would be adopted under their umbrella. This was on the basis not just of scientific validity, but on the commercial deals about access for the UK populace to the product or manufacturing base, and actually also some acknowledgement that we would try and undertake studies that would be for the greater global good, even if they weren't vaccines necessarily that would end up in the UK. If we have the infrastructure, can we undertake studies that would be applicable to more developed world settings, etc., developing world settings, etc. Now, these studies, if they are VTF badged, have an automatic route almost through urgent public health badging to being level 1. It's still reviewed at urgent public health, but the expectation would be they be accepted, maybe with some minor alterations. And so these are the highest priority in the country in terms of research, along with some of the platform studies for COVID therapies such as recovery, REMAP, CAP and Principle. And we had to try and do this with the existing infrastructure and systems, though there was some pump priming funding from the Vaccines Task Force. So how was it set up? Well, a regional approach where we're regionally set out, and each region was asked to appoint a vaccine lead. That could be anybody that was orientated. It could be infectious diseases, people with previous experience of vaccines, or it could be someone already in the hierarchy, for instance, the clinical director for that region. They would be aware of the local infrastructures, workforce, areas of interest, etc., and start developing regional models. At a national level, we set up a program board. We also developed or set up a delivery group, which was partly information giving to all the relevant people around the country and the devolved administrations, and also some high-level question and answer from the different regions. There's an ops group, a national ops group, which does more of the middle-level questions, for instance, about contracting, or if there are issues about IT systems, etc. And those take place weekly. And there's also a study placement and performance management group, which is involved in trying to facilitate the placement of studies in different sites, of which there are over 60 to 70 sites around the country now, and performance managing some of the studies. Work streams are set up, the clinical work stream which I lead, financial, logistic, workforce, comms, a whole variety of different work streams. And we had to maintain a balance between site, region, national and government. A lot of the planning being regional and national, the sites obviously delivering and reporting into government. So an example I'll give is Greater Manchester, because it's my region. So the plan we had was really what we call a sector-based approach. Other regions have done similar things or more of a hub and spoke model. So we divided Manchester into 5 sectors, aiming for a high throughput, high intensity recruitment and vaccination. Within each of those sectors, we had a lead trust. That lead trust would scope venues. We tried to encourage non-healthcare settings, because with waves of COVID, it's very difficult to know what your healthcare settings are going to be doing and whether they're going to be employed as hot wards, cold wards, or outpatient facilities. But also, actually, a lot of the public in the first wave were very resistant about going to hospital settings and healthcare settings, as they thought it would be unsafe to do so. So, for instance, in Manchester, in the southern region, we've used a rugby club in our eastern sector, and we've used a leisure centre, which I'll show some pictures of in a second. Now, that lead trust would be responsible for undertaking the study, but with a kind of one Greater Manchester approach, the sector trusts and actually people outside of the sector within Greater Manchester would support with staff, with experience, with facilities, etc. And our core CRN team would also support. So that's partly how we did it in Greater Manchester, or are doing it, and I'll come back to that. But what about more nationally? Well, let's break it down. We needed to find participants. So you may well be aware that a national registry was set up, which is really a consent to contact registry. Over 300,000 people, I think, have signed up to that. But that's fine having 300,000, but we need to convert that into people who are potentially suitable for enrolling. So pre-screening websites have been set up with varying success for all the different studies. So people from the registry can be invited to join the pre-screening website, give in basic details which cover some of the inclusion-exclusion criteria, and then those that pass are passed through to the research site, who have their own booking systems. On the day, most centres have developed a conveyor belt type pathway to enrol these people, and I'll touch on that in a second. And most settings have actually enrolled 30 to 70 individuals per day. On the bottom right there is COVID and Me, which I know you've got a talk on later on today, which is one of the excellent programs to try and encourage the registry to be enriched with some of the populations that we're low on, for instance, BAME populations, etc. So this is actually from Wessex, and this is a diagram which you don't have to read, but it's really just to show the kind of things that we've all done in our regions of the conveyor belt. So people come in at the bottom, they'll go from one station to another, to another, to another, to another, and go all the way round. And so the different stations would be initially consent, then it would be inclusion, exclusion, and medical history. Then they would move on with social distancing to having their baseline observations, move on to having their baseline investigations, etc., all the way to being vaccinated and then being observed afterwards. This is actually our Oldham Leisure Centre for me locally, and you can see that the layout of the flooring on the left there, and on the right an individual who gave permission for photographs progressing through the different stations and ultimately receiving their vaccination. In theory, when we've modelled this, you could actually enrol up to 200 people a day if you had enough infrastructure and enough staff to undertake it. So you're probably all going to be aware that we've got several studies that are ongoing, some that are fully recruited or very close to fully recruiting, but we're roughly where the horizontal kind of greenish, bluish line is, and you can see that the potential pipeline of VTF agreed studies is still quite rich. So we've got studies that are starting in December, January, February, March and April. This is a slightly fluid situation I'll come back to later on, but we've still got a lot of work to do. But the performance has been very good. So one particular study here is just about to meet its 15,000 target, which is, I think, a huge undertaking. And if you'd asked me at the beginning part of the year, could we manage this on a regional basis over this period of time? I think my answer would have been probably not. So there have been challenges. Things can change overnight, and in fact they did change overnight with a phone call at about 8 o'clock last night, where we may have to slot in yet another study with 3,000 to 5,000 people. There are increased asks for recruitment. One study was 9,000 to 10,000 and was increased almost overnight to 15,000 in terms of our planning. The timelines are shifting all the time for vaccine studies starting or being delayed. There have been issues that develop. We've had some very difficult protocols, which I think if it wasn't the COVID time, we might have pushed back a little bit more, but we need to get going on these. So there's been a lot of flexibility. We've had significant IT issues, I would say not actually on the NIHR or the NHS side, but really on the sponsor's side. And other areas that directly impact us hugely, but not under our control, are things like the national deployment of vaccines. Not just on the workforce demands, but actually on the fact that people are less likely to enrol from certain specific subgroups if they think they're going to get the deployed vaccine in the near future. And what do we do about those that have enrolled to placebo-controlled studies when we have a deployed vaccine of proven efficacy? So all these are issues which we're dealing with at the moment. But I'm pleased to say that the national system, has really successfully flexed, responded and adapted to these challenges. And there's been a lot of innovation. So again, just talking about Greater Manchester because I know it better, but there's been similar things in every single region. We're running maybe 6 different protocols concurrently with symptomatic pathways, etc. So we're developing a centralized call center approach. So we're not having 6 different rotas of people who could potentially answer the phone, but everything should be in the near future channeled through to one group of people who will then deal with the issues and pass on or signpost regardless of which protocol. And so it's about scales and economies of scales, really. And on the right-hand side, we've spec'd and will soon have delivered our pharmacy van, which is registered as a pharmacy, but we can drive up to these different venues, and it has the freezers within it, the fridges, the hoods, the admin areas, etc. And so this is something which will be a legacy for the future in our region as well. So talking about legacies, well, we've already had interest in high throughput rapid recruitment at scale for non-COVID vaccine research, perhaps later in 2021. I think the infrastructures that we've set up, the collaborations we've set up, should mean that we can undertake larger scale studies, we can perform better. And I think that's only going to be good for our population, our research infrastructure, and hopefully for you on the call here today. We are working to evaluate what we're now doing better than we were doing before, and to ensure that we try and take these learnings forward. And that isn't just in the vaccine arena, but it's in other arenas as well. the rapid throughput, getting things through HRA, MHRA, the prioritization, the collaboration on the UPH studies is all something that I think has paid dividends. In fact, on the therapies for COVID, I would argue that the UK has been hugely involved or solely involved in a lot of the pivotal findings that have informed international guidelines. So we need to take that forwards. We need to take our learnings from vaccine research forwards, and I think the future is hopefully quite bright. So thank you very much. I will drop down so I can see everybody again and take any questions. So thank you.
Hello, so thank you, Andy, for that excellent talk. That sounds like a lot of hard work.
It's been a lot of hard work for an awful lot of people, and I think, you know, I can't acknowledge enough that everybody from a site level to a regional level to a national level has really put the hours in and the effort in and thought outside the box. Otherwise, we wouldn't be where we are now. So if there's anybody on the call who's involved, thank you very much.
Yeah. So I think kind of for me, I mean, whilst we're waiting for questions to come in, enjoy is not the right word, but kind of one of the most important things that has kept me going is working with colleagues that I've worked with in the past, or making new connections with colleagues in different parts of the research and the NIHR. And so I wondered, what have you found to be the kind of some of the most rewarding parts, apart from obviously the kind of final results?
Yeah, I mean, I think, yes, I mean, obviously the final results are what we need. If we want to get out of lockdown and restrictions, then a vaccine is what we need. But we need more than one vaccine, I should stress. You know, job isn't done. In fact, job gets harder, and there's an awful lot to be done. But I think from a personal point of view, and also from a legacy point of view, it is those connections. It's people thinking outside the box. It's people collaborating in different ways. And that's been fun. And I know a lot of people quite well now who I hadn't met before a few months ago. But it's also, you know, if there's an RSV vaccine, if there's a CMV vaccine, if there's HIV vaccines, if there's something else coming along, we now have an infrastructure we can hopefully plug and play into.
Great. So I can't see that there's any questions that have come in yet, but do you want to share your thoughts about how things are going to be playing out with potential licensing of vaccines?
Yeah,
I think that's probably the kind of the question on everyone's lips.
I can see actually in the chat that I can access that Kat has just put a question in a bit like that as well, actually. So that's the difficult issue that we're grappling with at the moment. So deployed vaccines are obviously vitally important. There's a variety of impacts. So there's an impact on those studies that are enrolling now or soon to enroll, in terms of they may have to reassess the populations that they're most likely to recruit to. If they're wanting populations over the age of 85, that's going to be very difficult, particularly if they remain placebo-controlled studies rather than active control. But there is that impact actually on those already enrolled in studies, and the ethical impact of someone who is at risk of COVID potentially being on a placebo. And so there's some active work actually in the last 48 hours about developing a UK approach to this, defining it. We've known our thoughts for a while, but defining it at a high level, and then liaising with the sponsors and aligning with the sponsors. Now, I would expect the majority of studies would involve unblinding, and those that are on placebo would receive the deployed vaccine. Whether those that are on active vaccine would require the deployed vaccine would really depend on the most up-to-date information about the immunology, etc., to work out if they're looking promising. This will affect the scientific integrity of some of the studies, which is a big issue, which is why this is not something that is just, you know, one document going out. It requires aligning an awful lot of bodies, including the MHRA and the HRA too.
Okay, thank you. And can you see any more questions? So I can't see.
I can on the chat thing. Let me just see. Oh, there's a question about GMO. Okay. I don't know if so I can answer the question about GMO in relation to COVID vaccines, less so with other vaccines. So there's been derogation by the European Union, which has been adopted by the UK as well, that while there's still a pandemic as defined by WHO, we don't actually need all the procedures and things in place for GMO products that we would have needed before. So it doesn't need a local GMO safety committee risk assessment to be performed. Now, that doesn't mean we're not doing it. So we are developing a system, or have developed a system, where in that regional model, there are regional pharmacists who are vaccine orientated. And the lead LCRN for a study, the vaccine pharmacist for that study, will, with the chief investigator, fill out a risk assessment, which will be there available for all the sites nationally. So it'll be up to the individual site whether they sign up to that and use it. And we're doing this really so there is an even playing field, that there isn't different things happening in different sites, but also those sites that don't have GMO committees and GMO officers can have advice about storage, about preparation, about disposal, etc. So that was one of the questions that I saw popping up. There is another one, if you'll allow me, about how are we going to ensure that mass unblinding doesn't destroy our trials? That is a good question. Obviously, the power calculations were based largely on following both the placebo and the active control for a period of time and a number of events. Now, currently, the number of events are probably higher than we'd normally expect. We would hope that the majority of studies, the active arm, don't need to receive the deployed vaccine, but that's got to be assessed. It may be that some of the studies need to continue for longer. But this is exactly why there's been a whole flurry of emails and telephone calls in the late nights over the last few days while we try and plan for this. I would like to think that over the next few months we might be able to move into an era of active control with non-inferiority statistics, but let's wait and see.
Very much. I think that's all the time we've got, but I'm very grateful that you can still join us today. Let's do. Okay, so
Great. Well, thanks so much for the invite, and good luck, everybody, and thank
all
you
right.
so much.
Bye, Andy.